phase 3.
I was in a meeting in Nottingham the other night, Carol. I don't know if you were in. It was jolly nice to see everybody. Very nice. It's great we've got these volunteers around the UK who volunteer to look after our local members in whatever area.
Absolutely.
Jill and Wendy in Nottingham. And it's fantastic that they do that for us.
So I'm going to say hello. I'm going to say welcome. I'm going to welcome James, Professor Neuberger, as he's known on Wikipedia. So thank you very much for joining us. Chief, I'm going to welcome you as well. So hello and welcome.
Thank you.
For joining us being here. But before we get any questions, can I ask you just to chat a wee bit about what we're doing with the members' meetings and what we're doing online and what Linda's up to, and just make sure that
I'm just going to do a vlog for the volunteers, the UK volunteers. So I'll be doing that for hello Diane, any volunteers that are in. So Linda looks after the volunteers, and we're going to start some training. So she's liaising with everybody at the moment and Robert as to what times and days suit everybody. As you know, we're continuing to do the 4 o'clock session 6 days a week, but with the whole world opening up starting from next week, that will be under review. We'll have team meetings, and we're listening to our members as to what you want. I know a lot of you are thinking, well, it was good, but maybe we don't need as many. We're going to continue with our 2 o'clocks with whatever doctors will speak to us, which is wonderful. Every Thursday, that is fantastic. And Robert is going to have set his new timetable for May regarding his sessions on a Tuesday, which is really all about looking after yourself. The aim we have, at the foundation is to keep you informed, give you support, and help you live a normal life as possible. And however that may be, so it's everything. We're trying to give you a thing in all different mediums, and of course we continue with the bare facts. We're planning a bumper issue. Alan wants you to have a bumper issue, because of course this is our 25-year celebration, which we're going to be talking a lot about. And Robert's got a lot of planning to do for International PBC Day. He played such a stormer last year. How he's going to beat that? Wait and see. So we've still got lots on for you, and we're always here, and we take, as you know, calls at evenings and weekends. Have I missed anything? I usually do, Robert.
So just a little more detail about the regional meetings for all that are online. So therefore, technically they could be anywhere, but what we're trying to do is create those local communities and bring people that live together in areas together. So I just wanted to give you the opportunity to talk about that really for a second.
Well, yeah, because that's what Linda's in contact with the volunteers now. So she sets up click meetings so as you can all talk online, but in confidence, because Zoom is open to hacking and Facebook, certainly anybody or everybody can hear what you've got to say. So our volunteers give Linda dates, and Linda sets them up, and you can join any meeting. I mean, you can be in Nottingham and you can join London's meeting, anything you fancy if the date suits you, but that is ongoing. So Linda is at the moment liaising with the volunteers to get the dates in for May, and we'll get them up on our website as soon as possible. But we are keeping our online presence and of course for you to meet with each other and to do these bigger issues with ourselves in the office and our doctors, our medical advisory board. We will keep you fully updated, as we're updating at the moment, about COVID and vaccines. We'll talk about that just now. I'll introduce that once it's ready for us. Hello, Jean from Liphook, and we'll keep you updated. You know we're good communicators. Well, I am anyway. Should we put it that way, Robert?
Yeah. Well, yeah. Right. Anyway, so yeah, you brought up the subject of the vaccinations. I know we've had a few questions and a lot of concerns kicking around. Is it worth opening up today's session with a little conversation on that, James?
Yes, please. So I emailed James last night because we've had a few inquiries. Obviously, there's talk regarding AstraZeneca. We're looking at what we have on our website. James has rewritten it, and it's gone round to our worldwide medical advisory group. For example, we just had a message in from Canada just saying some of the differences they have there, what they work with. So can I come to you, James, to really, people are becoming nervous and concerned, and I wondered if you could keep us informed.
Right. I mean, I'll give you my view for what it's worth. They say advice is worth what you pay for it, and mine is free. So that tells you something. I would also, as Collette said, I have today updated the guidance from the foundation for the medical advisory board. Alan actually has sent it round to all members of the MAB, because it's not just my views or Colette's views or Robert's views, it's a collective view of the MAB, which contains not just the UK, but the international perspective. So hopefully we've already had some constructive comments back, and hopefully on Monday we'll be able to issue the revised guidelines. A number of things to say, really. Firstly, it's very important when you look that any medical intervention has risk, and you always have to associate risk or correlate risk with benefit. And that's just not true of medical intervention, that's true in life in general. If you drive, say, from Manchester to London or Manchester to Edinburgh, which is around 250 miles, there is a chance that you will have a fatal car crash. It's a fairly remote chance, but it happens. If you climb up a ladder to, I don't know, put your hanging basket up, there is a risk that you will fall, break your neck. People do. If you go horse riding, as Collette mentioned to this journalist, there's a chance you will fall off and break your neck. There's a chance you will die, and so on. Everything in life has a risk, and consciously or not, you balance that risk. When you decide to go to, in those days when you go to Spain for your holidays, there's a risk that you're going to die on the journey there and on the way back, but you discount it. So life is full of risks. The risks for the majority of things are relatively small, and people on the whole are remarkably poor at assessing risk. So we'll see somebody who will spend £1 on the lottery or not sit in row 13 of an aeroplane, but smoke. And of course, more people die from smoking per hour, I should think, than die from walking under ladders. And yet, so people are, thank goodness, it reassures your faith, people are illogical and not very good at handling risk. The chances of you getting murdered is actually far greater than if you are than having a major win on the lottery, and so on. So we don't really consider risk properly, but everything has a risk and everything has a benefit. The second point, which is distinct, I want to make, is that people know, regulators know, doctors know, nurses know, patients know that interventions have a risk. And when you have a new intervention, such as a vaccine, what you do is you ask people to report any adverse reaction. And the problem then becomes twofold. One is to say, is there a link between the vaccine, in this case, and the adverse event? If you're giving a vaccine to 30-odd million people, as we've done in the UK, particularly most of them are elderly, they're over 70, many of them over 80, you know that within the 2 weeks after the vaccine, somebody's going to die, some will have strokes, and so on. And there's a whole lot of science and statistical expertise to look at whether an association is real or fictitious. So, as David Jones said, I think previously, that the day after he had his vaccine, his car wouldn't start. Now, most people, I think, would discount a causal relationship. But if you get rare events and you're monitoring them, you may pick up false signals. And furthermore, that if you have publicity about any one adverse event, then more and more people will report that. So statistically, you can say there's an association. there is an association, for example, we've used this before, say between the age of the number of telephones and let's say the homicide rate. The homicide rate is falling, the number of mobile phones is rising. Now, do you think there's a causal connection? Probably not, and so on. So an association doesn't mean causation. So the regulators are finding it very challenging to compare the risk with the is there a cause? Does the vaccine cause damage? Yes, we know that vaccines can cause problems. Some of them are the simple ones, I say relatively trivial, of ache, of pain, of fever, and so on. But very, very occasionally, there are more severe consequences of vaccination. So you have to balance the risk of vaccination against the benefits. We've seen in the UK, like they have in Israel, like in other countries where they've had mass vaccination programs, that the death rate from COVID has fallen dramatically. And I don't think there's been a single death in anybody who's had COVID vaccination from COVID in anybody who's had the second dose of COVID vaccine, whatever the vaccine. So there is a risk, but there's a huge benefit. And as I said, some of my patients are concerned, and my response is usually I can take them to the hospital and show them literally hundreds of people in hospital with COVID. I can give them hundreds of names of people who've died of COVID. I can give names of people who are suffering from long COVID. What I cannot do is give them the name or details of anybody who's had a major adverse reaction from the vaccine. So the benefits are huge, the risks are there, and they can be serious. Now, with the clotting episodes, which are clearly of concern, the way most governments or jurisdictions have responded is to restrict the AstraZeneca to those who are older. And the rationale is quite sensible, that the benefits of vaccine are greater in the elderly, because we know that of all the risk factors, there are two major ones. The first is age, far and away trumps everything else. The second factor that I think is that most studies show, the second major factor, is actually gender, with males being far more at risk than females. People who are immunosuppressed, people with advanced liver disease, also have greater risk of not of getting COVID, but dying from COVID if they get it. So the risks of COVID are with the elderly more than the younger, and therefore the benefits of the vaccine are more with the elderly and those at risk. Conversely, those who appear to be at more risk of getting thrombotic episodes, whether or not they're related to the vaccine, are younger people. And therefore, they're being sensible, they're being precautionary, and looking at the risk-benefit ratio and saying the benefit of AstraZeneca compared with no vaccine is much greater in the older population, and therefore equally people with advanced liver disease, people who are on immunosuppression. Whereas the younger, healthy people like Robert there, again, he'll have less benefit, because if he does get COVID, it's much less likely to be serious. And because, as far as I know, he's got no comorbidities, the chances of him dying is very small. So it's being precautionary. In the UK at the moment, they are not offering a choice of vaccine. There are various arguments for that. Of course, remember the AstraZeneca vaccine, yes, has to be given as 2 shots, unlike, say, the Johnson & Johnson one. But in terms of cost, it's $3 rather than $35 for the Pfizer one. And in terms of storage, it can be kept in fridges like other vaccines and not at -70. So the advice that I think will be agreed by the MAB is that, particularly if you have PBC, and if you're older than 30 or 40, then take whatever vaccine you are offered, because the benefit of the vaccine is far greater, not only to you, but your loved ones and your family. And they're not always the same thing, I know. The benefits are greater than the risks. But to say there are no risks is clearly naive and wrong. But there are several examples where people have attributed sometimes side effects. If you remember, I think DuPont Chemicals made breast implants, and there was this very public discussion about women who had the breast implants getting rheumatic diseases. And it was such a large outcry that they stopped making it, and I think the company that made them went bust. When they actually looked at it in more detail, they found that a lot of people, a small number of people who had the implants, did develop rheumatic diseases, but so did a similar proportion of women of that age who didn't have implants. And of course, the reason is that women who are likely of an age to want to have breast implants or need to have breast implants, it's the same age group of those who are at greater risk. And to say, and unless you look at the control group, if you like, the people who didn't have breast implants, to see if there's any difference. So on the other hand, if you look at thalidomide and how long it took for the regulators to realize that thalidomide caused horrendous birth defects in children. So I'm not saying the regulators get it right all the time, they don't, but you have to balance. Let me give you one final example before I stop, and I've gone on a bit longer than I meant to. There was a drug called I think it was propranolol, that was developed in the UK, in fact, as a beta blocker that was very good for blood pressure. I think it was propranolol, I may be wrong. The US delayed introduction by several years because they wanted to do safety checks. It's a very safe drug, and they estimated that several 100,000 deaths were caused in the States by the delay of the introduction of the drug. It was done for safety reasons. So it's a very difficult job the regulators have to do. They're looking at the information, which has to be evaluated. And we've seen, again, give you another example with hepatitis C. I've seen people who have got hepatitis C who've attributed it to a blood transfusion. And when you actually look in their records, they never had a blood transfusion. So it's very difficult. There is a potential link which people are exploring of how the vaccine might induce thrombosis and clots, but it's still unproved. So yes, it's something to be concerned about, but to make sure that the regulators are looking at all the data, evaluating it carefully, and ignoring those people like the journalists who don't have access to the data, who don't have the analytical skills to say, is this a real association or not? Yes, to be cautious, but I've had my vaccine, but if I was offered today a vaccine, I'd jump at the chance, whether it's AstraZeneca, Pfizer, Moderna, or one of the other ones. I'd go for it because I know that my chance of dying are far greater without the vaccine than with. So I'm sorry to go on, but I hope that helps.
Yeah, there's two things I would say to you that somebody's put up on the screen. Jean Coulthard is saying that her daughter, who's under 30, has cancelled the vaccine. Maybe suggest that your granddaughter goes on YouTube and listens to what James has just said these last few moments, because we can't make decisions for people. They have to make their own. But the other thing is about the vaccine, when you are going to or not take the vaccine, it's not just about you. As James said, it's about the family, the people that you're interacting with. You know, if young people, teenagers don't get the vaccine and they're seeing their granny, their grandparents, how safe are the people they're that they're interacting with going to be. So all of that has to be considered when somebody makes the decision. It is a very individual decision, but it's not just yourself, it's other people that are being put at risk as well.
The chances of dying from the vaccine is said to be the same as driving from 250 miles and dying in a car crash. So if your granddaughter is commuting to London, I don't know how she's going there or driving. But again, it's not just deaths from COVID, but also long COVID that she would be putting herself at risk at unnecessarily. It's her decision. Yes, one respects her decision. But people have to live by it. And of course, if she decides not to have it and she gets COVID, I hope not, and gets long COVID, she can reflect whether it was the right decision or not. But equally, if she's under 30, she wouldn't be offered the AstraZeneca at the moment in the UK, and that's the one where there's questions raised. So yes, she's entitled to her views, but
I
would advise. I don't. Yes, I think you know what I feel.
Thanks, James. Thanks, Robert.
Perfect. Helpful. Thank you.
Yeah.
Okay, so I've actually got a couple of questions with regard to vaccination. We've got somebody who is in Australia, so sorry about that. But they're saying that the comments just came in and then the comments disappeared.
Jean was saying that the girl's been offered the AstraZeneca.
So bear with me. So Nicole comment has just disappeared off Facebook, which is interesting. So, but the comment was that they are a non-responder to medication. They're fairly far on in their PBC journey. Any thoughts on what they should be doing with regard to the COVID vaccine?
They're in Australia.
Yeah.
You say. Again, I mean, I don't know what the vaccination program is and what the advice is from the Australian authorities. And of course, in Australia, the rates of COVID are a lot less than they are or were in the UK. So you may argue that the risk-benefit balance is different than it is in the UK, which it probably is. But again, my feeling is that whatever my liver was like is like, and if I were offered the vaccine, I'd go for it.
Right.
But the risk, again, it depends which vaccine it is, and what the risk of getting COVID is. But I would go for it.
Okay, perfect. Right. All right.
I can see the lady whose granddaughter's refused a vaccine is saying the girl was offered the AstraZeneca. Could well be at the time she was offered that it wasn't for the under 30s, and it's changed just recently, Jean. And you're saying because she lives with me, because you're extremely clinical vulnerable. I don't know if she is still living with you, but that's quite a serious situation, really, isn't it? And it's really up to the two of you to have a chat about it. And as I say, if she is still living with you, Jean, well, maybe she needs to, if you can show her, ask her to have a look at this, what James has had to say, and listen to his words, because this affects you as well as her. And James is saying that under 30, no, she would not be offered it now. So she might want to rethink. But best of luck, Jean, and let me know how it goes.
Okay, perfect. Thanks both. Okay, so I'm going to move on from the vaccines then to PBC related questions. So I'm just going between screens. So my first question, is there any link between PBC and raised SHBG? Now, I've no idea what SHBG is. So
right, SHBG is sex hormone binding globulins.
Where did they make these words up?
Well, it does what it says on the tin. Hormones are carried around the body from where they're made to where they're needed, with a variety of different proteins. Albumin, for one, is one of the roles of albumin, which people will be aware of, is to carry a lot of protein, a lot of chemicals as a transporter. The relationship between SHBG, I know there are disturbances in liver disease in general. I'm afraid I have to look up and can't tell you off the top of my head what the relationship between SHBG and PBC is. But I know there are disturbances of SHBG, but you need also to look not only when you're looking at the hormonal changes, you've got to look at the total levels of hormone as well as the binding globulin that carries them. So it's a complex area, and I don't know the answer, I'm afraid, but there are abnormalities because the liver makes a lot of the globulins and other proteins.
Okay, that's helpful. Thank you. Okay, next question for you, James. So we've got somebody whose ALP was 249 at the end of January and 309 at mid-March. But they're asking, what causes this to be raised, and is there anything I can do about it? I don't know anything about medication or anything like that, so I just a nice general question.
Right. There are many causes of a raised ALK phos. Obviously, the ones we're interested in are produced by the liver and the bile ducts, but ALK phos can be also produced by the bone, the placenta, the gut. So a high level is not necessarily liver related, but in general, and certainly in PBC, the liver ALK phos parallels the gamma GT, which is why we measure that. There are in normal people fluctuations in all the chemicals one measures in the blood. Some of it is due to diurnal natural change. Some of it is due to the way samples are handled. Sometimes it's the way they're analyzed. So, for example, if you have a long interval between taking the blood and analyzing it, your ALT and your bilirubin will be increased, and so on. So a rise may just reflect the way things are being handled, the measurements, normal variation. If you measure your height 3 times, it's unlikely to be the same each of those 3 times. And equally with the ALK phos, it may not be the same every time. Sometimes, depending on the lab, they dilute the blood if they're high levels, because the machines are geared towards normal ranges. So you may get variations in that. So if the ALK phos is rising, it could be something to do with the liver that you're not getting treated, but there's quite a steep rise. It could be due to something else that's going on in the liver, not PBC. And there are many causes of that, gallstones, for example, medication, and so on. It could be if you've got bowel problems, bone problems, you've broken your leg or something, or you've got a growth spurt, something that we see in teenagers, not in people with PBC usually, that will put your ALK phos up. If you become pregnant, that'll put your ALK phos up. But if you get a change in a short period of time, my advice is really to repeat it fairly soon. If there's an increasing trend, then I'd want to find out why. If it fluctuates, I wouldn't be too concerned. But although the ALK phos often rises in untreated PBC, it doesn't rise that quickly. So if it's had a jump unexpectedly, and you can't attribute it, say you stopped taking the urso because you ran out, for example, then repeat it. If it's still going up, then I'd want to know why and investigate further. If it's the same or falling, then I'd just sit tight and keep an eye on it.
Okay, perfect. That's helpful. So whilst we're on the subject of ALK phos, now I know the Chief and I will have that's one answer, but James, the question is, what is the determining factor for somebody going on to a second line therapy? So we've had somebody who's consistently been between 240 and 400 with their ALK phos, but they're still only being offered URSO. So can you give a clinical view? And then maybe, Chief, if I come to you shortly for a PBC Foundation view in terms of patient advocacy.
I mean, in general, there are two reasons for people going on to second line or being offered second line therapy. One is they can't tolerate URSO, and some people find the bloating and the other side effects unacceptable at a therapeutic dose, or they fail to respond adequately, and we've got the measures, as you've written about, to say whether. So, as a rule of thumb, if it's below 240 is a sort of cutoff that I use as a rule of thumb, but it varies in different models, and different units have different levels. So, if you're taking URSO, if you're taking it at the therapeutic dose, 13 to 15 milligrams per kilogram per day, and your ALK phos hasn't responded, then I'll discuss with your doctor why they're not considering either OCA or fibrates or experimental treatment. And I'd ask them why not. There may be very good reasons, but clearly if they need to be explained to you, and you need to understand and accept them if they're valid reasons.
Okay, thank you. Chief, any thoughts?
Well, it's quite clear. If you want to look at the PBC guidelines, they're on our website, and we did send them out with a newsletter some time ago. We can always send you another set, but it says quite a lot about second line therapy. So do read that, and as James says, have that discussion with your specialist. That's very, very important. You understand why it is you're not being offered treatment, or why you shouldn't have the treatment. That's very important. It shouldn't be because they say no without a reason. You need to have reasons.
Absolutely. And James, James, please.
I was going to say, sometimes if you haven't got your appointment for a while, you can always write. And it's when you write to your doctor or nurse, it's always quite good because they write back. It's on the record, and then they can't say, "Oh, that's not what I said," or "You misunderstood me," or whatever. If they're written back because I don't like you, then that can be used in evidence against you, as it were. And so it makes people, and to put a very simple question in a non-aggressive way, the guidelines say that I understand. The guidelines say this. Why am I not being offered it? They've got to respond and say, well, this is the reason why not, or yes, I should have done it.
Yeah.
And if you don't get a good response, ask your GP to refer you elsewhere.
Yeah, but don't be afraid to ask. There's still a bit of this going on with us older people, is that you're afraid to ask and the doctor knows best. It's meant to be teamwork and you make joint decisions together, but please don't be afraid to ask your doctor for anything.
Yeah, absolutely.
And bring a bottle of whiskey with you. Champagne.
It's called bribery and corruption.
Oh, yeah.
We'll keep it in bribery.
Listen, I just for the record, I'd want a case, not one, but.
So we're back to advice is worth what you pay for it again.
Yeah.
So back to on a more serious note now, if you've been paying attention to the app and the surveys that we've done through the app and all of those kind of things, we've been highlighting gaps in best practice. So again, I can't off the top of my head, I don't have James's memory, so I can't remember all the statistics, but we're still looking at in many countries or many situations, patients who are still not necessarily on the correct dose of URSO in terms of the 13 to 15 milligrams. We've got patients who are not necessarily responding to URSO, who are then not given the opportunity to go into second line therapies, or as James said, to go into clinical trial opportunities. All of those kind of things are happening. So it's really important that you inform us So use the surveys, answer the surveys, and let us know so that you can join the collective voice, but also use the information, use the data from the foundation to then bolster your arguments and allow you and empower you to ask your questions. And the other thing I would say is that you're not alone in this. And for example, and James may want to say something about this very shortly, but there's about to be a nationwide PBC audit in the UK. Now, when this was raised at the British Society of Gastroenterology conference online, one of the pieces that were cited was actually a survey done by the foundation highlighting the gaps in best practice. So it was important to let you know that no, you're not alone in this experience, but you can advocate for yourself and you can use the information that's available to you to help you, obtain that best practice level of service.
Okay, may I just add the PBC audit? I'll probably know more about it than you, James, just on this one little bit. But if you know more, come and tell me. So Dr. George Mills at Cambridge, Adam Brooks in Cambridge, is one of the leads in this piece of work. Every single hospital in the United Kingdom that's holding PBC patients will be asked have been asked to take part in the audit. It's called the PBC audit. George is, as we speak, he's putting an article together for our next Bare Facts, and he will explain to you what's being done so far and what some of the findings are and how long this is going to last and all the detail about it. But it's absolutely fantastic. I'm really excited about this because this, with your help, will help us identify the haves and the have-nots, and it'll help us also have uniform treatment across the United Kingdom. And if the United Kingdom managed to do that, believe you me, all the other countries, I know we've got people in from America and Canada today, then they will follow suit. So I'm really excited about this project. Are you part of it, James? Is there anything you can add to that?
No, I mean, I'm not. This will have gone to my colleague, Dr. Trivedi, who...
Oh, yeah, we'll see him next week. Yeah, Palak.
I'm half retired, so he's leading the service and very well. But I think, I just want to make one point. I think that, or 2 points. One is no doctor wants to provide a second-rate service. And secondly, PBC is not unique in not everybody receiving the optimal treatment. But where I think PBC does stand out is that there is a PBC Foundation that will spearhead and lead to do these audits in a non-profit making way. So it is very good to have these data. The key thing is for the data to be generated and then to close the loop so that once you know the extent of the suboptimal practice that you can correct it. And of course, there's some reasons why people don't have the full amount of the recommended ERSO. Some are very valid reasons. They don't tolerate it, others don't want it. And one question, which I'm still not sure the data is there, is that if, say, you're taking 10 milligrams per kilogram per day and your liver tests are normal, does that mean you're taking enough ERSO for you? Or does it mean you're still being undertreated? We don't know that. I've tended to go for the full dose, but some people have argued with justification that if you've normalized the liver tests, you've got the ERSO effect. You don't have to take 2 paracetamol to get rid of your headache if 1 will do. So that there may be good reasons, but they ought to be explicit and clear to the patient.
Yeah.
But it does depend on the patients flexing their muscles and using the app, feeding back, because with data, you can make changes. With case reports, you can't.
Yeah. Perfect. Okay, that's helpful. Thank you all for that input. James, I'm going to come on to now ERSO post-transplant. Now, again, there was data that was released in France. Some clinicians have kind of jumped onto new practice. Again, some clinicians haven't necessarily. but we've got 1 or 2 patients that have been offered URSO post-transplant without their PBC coming back or without any indications of their PBC coming back. And I guess they were just concerned that, was there something happening that they didn't know about? So can you maybe talk a little about URSO post-transplant, please?
Right. Again, if I can step back a little bit, the way to diagnose recurrent PBC or PBC post-transplant is the only way you can diagnose it with confidence is to do a liver biopsy and show the classical histological features of PBC on the biopsy. You can't, the AMA persist irrespective of recurrence, and the liver test, the res-alk-phos, particularly in the transplant context, has many different causes. In the early stages of recurrent disease, the lesion is patchy, so your biopsy may not pick up the specimens, the lesions. But what is increasingly clear is that PBC does come back in the new liver or the second-hand liver, and it can, on occasions, affect the graft function. And over time, the number of people with evidence of recurrent disease is increasing. Now, the paper that Robert was referring to was a retrospective study of 19 centres in 6 countries, if I remember rightly, including the UK. And people went back to all their cases of transplanted PBC, and they looked at where there was histological evidence, so proven recurrence, and looked at whether they were on URSO prophylactically or not. And by prophylactic, I mean because they were transplanted for PBC. And what they concluded was that graft survival, which is how long your liver lasts, and patient survival was significantly greater in those people who've had URSO from the start of transplant. And over a 20-year period, that equated to 2.25 extra years. Now, there are many flaws with that because it's retrospective, it's selective, you don't know why some people were given URSO and others not, and so on. To me, that was quite a landmark paper because it did seem to suggest very clearly that giving URSO was a good thing in preventing recurrence or the effect of recurrence. It does increase the blood test, okay, but more importantly, graft survival. It's flawed, it's not 100% robust, but given the safety of URSO, I now recommend all the transplant recipients, and this is policy in Birmingham, to go on, once they're over the operation, to go on URSO, standard dose, 13 to 15 mg per kg per day. It is an extra tablet, but the side effects usually are minimal. It's likely to do good and prolong your life and the quality of your life, and very unlikely to do any harm. So the evidence is strong. It's not 100%, but I think it's strong enough that's persuaded me to recommend it to my patients. If you can't tolerate the URSO, then whether OCA has an effect hasn't been shown, and that's another question for another day. Whether fibrate should be used is a question for another day. But the evidence for URSO is compelling, but not absolute, in my opinion.
Okay, thank
I
you.
hope that helps.
Indeed, thank you. Chief, any thoughts?
No, I guess fair. I just wish all the liver units adopted that attitude, but what can you do?
Indeed. Okay, thank you. So next question, in terms of PBC medication. Somebody's fractured a bone in their foot and they're wondering if they, what painkiller can they take other than paracetamol? So again, not a specific answer to this one case, because that's what we do here, but if you can give some general advice, that'd be helpful.
Pain relief in PBC is always a challenge. the problem is that the non-steroidal anti-inflammatories like ibuprofen and so on have significant side effects. They can increase the risk of gastritis, of gastrointestinal bleeding, and renal impairment. So, on the whole, for anybody with liver disease, we tend to advise against non-systemic, that's by mouth, anti-inflammatories. Although the topical ones, Brufen gel and those sort of things, do get absorbed to an extent, for most people, the amount absorbed is relatively small and they can be used usually with safety. The problem comes when paracetamol above 6 tablets a day doesn't control the pain, and physical treatments such as heat, cold, whatever, don't control the pain. And normally, again, unless your liver's at a very early stage, and this is my own practice, it's something you'd need to discuss with your doctor. If it's not an early stage, is to avoid non-steroidals and go for the sort of stronger ones like tramadol, codeine, dihydrocodeine. They do have more side effects. There is a real risk of dependency, but again, one has to balance pain relief with the potential side effects. So a lot depends on your state of the liver, the amount of pain you have, and the rest of you, other comorbidities and so on. But it is a difficult one. But pain, contrary to what they used to think, the monks used to say, doesn't ennoble the soul. It just makes you hard to live with, and should be avoided. So if take proper paracetamol in proper doses, try physical things like heat or cold or compression or whatever as may be appropriate. And if that doesn't work, talk to your GP and find what works for you. But again, usually avoid non-steroidals.
Can I just add to this? I have huge sympathy with whoever's asked the question, because after my husband died, being very clumsy, I broke my wrist, my elbow, my scaphoid, twice bones in my foot, and various other things, and ended up with 11 points on my license. I do have sympathy with you, but I have heard people say that dihydrocodeine can make people a bit sick. But cocodamol seems to sit well with people. But again, ask your doctor about it. And I would also say to you, I don't know if this is a recent injury, but any fracture, normally after 2 or 3 weeks, the pain is a lot lighter than what it was in the early days that you break something. It's quite remarkable how it can be healing away and it's not as painful. So maybe it's just you need something short term. But do check on the cocodamol, because I hear it over and over again. It seems to sit a bit better. So it's worth a try. Don't get points for your license.
Okay, thank you.
Points don't always mean prizes.
No, they do not. Driving around for 4 years with 11 points was not easy.
Okay, perfect. Thank you. Okay, we've got somebody with PBC who also has Raynaud's and scleroderma. And the question is, so they've got weird growths and spots on the body, several around the mouth, nose, chest, back of neck, arms, and torso. Is this something that's linked to PBC? Is it a side effect, or is it a comorbidity that we're familiar with? Is there anything we can do to help?
I think very clear message. If you're getting lumps and bumps, go to your doctor and have them looked at.
Get them looked
period.
at. Yeah.
End of.
Yeah.
Okay,
perfect. That's helpful. Okay, well, somebody.
Can I? Sorry, just.
Yep,
I mean, sometimes people don't go for fear of what it might be, and that's understandable. That's rarely the case, but of course it can be.
Yeah.
But don't worry. Find out what it is, and fear of the uncertainty is far, far more harmful to your health than knowledge of bad things.
Yeah.
So find out what it is, find out if it needs treatment and what that treatment is. But most of them are not nasty, but of course they still can be. But find out what it is, get them looked at.
Yeah. Okay, that's perfect. That's helpful. Thank you. Next question was had somebody who's had a FibroScan of 75 in 2013. They had a gastroscopy in 2016, which showed no varices. Should they be having another scope?
In general, yes.
Okay.
A FibroScan of 70 odd is very strongly suggestive of cirrhosis, although you do get high levels in other conditions. And the advice is that people with cirrhosis should have an endoscopy looking for varices if they're present. If it's grade 1, they should be repeated at a year. If they're more than grade 1 or evidence of bleeding probability, then treatment should be offered. If there are no varices, repeat every 3 years. I have to say that with COVID, with the pressure on services, the reduction in the number of endoscopy slots available because of the need to clear the room, disinfect the room, and all the rest of it, the endoscopy services have been under strain. But as I say, the recommendations, as I understand them, is presence of cirrhosis, no varices, repeat endoscopy in 3 years. That's the rule of thumb.
Okay.
It may be delayed at the present time because of the COVID, but that's the guidance as I understand it.
All right, thank you. Chief, any thoughts?
No, I think you've covered it quite well. Thanks, Jane.
Perfect. All right, thank you. So we've got somebody here who has PBC, AIH, and long COVID. So, again, if we can help or support in any way, please do let us know. But the question is, they cannot seem to be able to control their body temperature. So I guess the question is there anything they should be asking? What can they do next? Anything to do with their PBC or AIH, or liver disease in general? Or yours, Jane?
But when they say a temperature, do they mean if they actually having a temperature and then it's dropping back to normal, or are they getting hot and cold without having a raised temperature? Do you know?
It just says they can't control their body temperature.
Right. So I wonder if they're getting hot and cold then, James.
Yeah, I mean, I think you're absolutely right. If you have a fever, their temperatures are particularly above 38, then it is usually almost invariably due to bacterial or other infection, and that needs identifying and treating. If you're feeling hot and cold, but your temperature is normal, that maybe it's seen with liver disease or with any other disease or with long COVID, and there's treatment for that is symptomatic. But the key thing is if you feel, is to take your temperature, and if it does fluctuate away from the 37 by more than a degree either way, to let your doctor know. But if it's not fluctuating and you're feeling hot and cold, that is more likely to be a long COVID phenomenon than the PBC or other phenomenon. But a fever or a low temperature, again, needs investigating, absolutely.
Okay, perfect. That's helpful. Thank you. So I'm aware of time, so last couple of questions, if I may. Somebody's got mild portal hypertension, scans, consultation every 6 months, endoscopy, colonoscopy every 2 years. Should they be asking about medication?
Medication for?
Well, I guess what's causing their portal hypertension.
If they've got PBC and they've got portal hypertension, then it needs treatment only. You only give treatment if they're varices that are likely to bleed. So very small varices you don't usually treat. And the evidence is actually it may do harm rather than good. But grade 2 varices or other markers of likelihood of bleeding, again, 2 ways of treating varices. And I see there's one question of varices are basically varicose veins, dilated veins in the gullet primarily, but they can be anywhere in the GI tract. So you either treat the varices to prevent bleeding, you either ban the varices through the endoscope, put rubber bands on them so they clot, or you give medical treatment, usually with a drug such as carvedilol, which reduces the portal pressure, or some people do both. Whether banding is better than medication or combination is still being investigated. But portal hypertension per se, not necessarily. Varices, maybe, depending on the varices.
Okay, perfect. Thank you. Sorry, I must apologize. There's a slight delay between James' audio and his video. So when James's tone of voice suggests that he's finished, I look at the screen and he's still talking. So I'm not really sure whether to come in or not. So I apologize if there's a slight delay there. Yeah, that's helpful, James. Thank you. So last question of today then. And it always takes me back to this classic moment when ursodeoxycholic acid leaflets used to say, do not take with a liver disease. So that's somebody who is considering taking fenofibrate, but it says on the leaflet, do not take if you have a liver or kidney disease. So again, can you just give a little general information either about fenofibrates, about these leaflets, and about hopefully what people
realise this is what lawyers get paid to do. This is legal belt and braces. That's what that is. Yeah, I've got one more question, by the way, Robert.
The wording on the leaflets, on the patient information leaflets, has to be agreed with the regulators. Sometimes there is no evidence that it is safe. And for example, with urso in pregnancy, because urso wasn't studied in pregnant women, there was no evidence to say that it was safe, and therefore it was considered not to be used. And yet the evidence is overwhelming that for cholestasis of pregnancy, use of urso not only saves the mother's life, but saves the baby's life and saves premature labor. So it is now a standard of care. And I would argue if a mother has cholestasis of pregnancy and doesn't get offered urso, that is negligent. And yet the guidance will say otherwise. So you need to look at the evidence. You need to say, why is it there? Is it because it can be harmful? So for example, statins, again, people use with caution in liver disease because statins can cause abnormalities of the liver. But those with liver disease are at no greater risk. And indeed, those with fatty liver actually will benefit from statins. So look at what it says. And if there's any contradiction or what you're advised contradicts what's in the leaflets, ask your doctor, double check. Sometimes we get it wrong. But with fibrates, for example, your doctor can explain the evidence for the benefit of fibrates and why they are recommending it for you. But do question. And I say, I'm glad you read the leaf. It's amazing how many people don't. But if there's something that raises concerns, clarify it. Your chemist probably won't know because they understand about pharmacology far more than they do about pathology. But the doctor who prescribe it, and particularly with something like fibrates, where you don't have to take it that day, you can ring or write to your doctor and say, I'm a bit concerned, can you reassure me? But in general, fibrates can be used safely with PBC. They need to be used with caution because they can cause abnormalities of liver function, as indeed so many other drugs can. But always challenge, always ask, and your doctor should be able to give you the answer. And if they won't, then one finger up and find another.
Okay, perfect. Thank you. So just double checking, when we talked about banding, did you cover whether or not banding is painful?
Not to the person doing the banding, certainly. No, it's uncomfortable for all those who've had an endoscopy. It's uncomfortable. Banding usually doesn't hurt. It's not like banding of piles, which I gather can be relatively painful. But the before banding became universal in the treatment, people used to inject sclerosant into the veins, and sometimes they still do. And that can be painful if it goes outside the veins. But in general, banding itself is not painful, although the endoscopy is often uncomfortable, and I'm afraid there's not a lot one can do for that.
Yeah.
Take the drugs. Take the drugs.
Thank you. Okay. Right, James, I believe that was our 50th
Wow.
Q&A session on a Thursday, and I know you've done the huge bulk of them. So again, as ever, thank you so much.
So well done for you for organising them. Yeah.
Your time, your expertise, your patience, and your willingness to put yourself in the fray. So thank you very much for that. Chief, as ever, thank you very much again to you. I'm going to hand over to you now. And my last word is thanks to everyone for all their great questions today. Thank you.
Well, I'm going to thank you, Robert, because you're actually on holiday this week and you've been doing your 4 o'clocks and you've come in today. So thank you. Everybody, we have worked hard, the whole staff has. Nobody's had any proper holidays since COVID began. So we're going to try, we're having a team meeting next week. So there'll be some changes, but the staff need to get breaks. But Robert, very much appreciated. James, now a wee whisper reached my ear that you've been invited along to be giving people vaccines. So the thought of you injecting us mere mortals is not easy, not funny. Well, do it nice and don't hurt people. I had an army sergeant do mine.
All right, well, I'll tell you, when I had my vaccine, this is what I was given.
Oh, the wee sausage.
Do other people have that?
I've had my vaccine. No, I've not got one of those. No.
That must have been because he was very brave.
Yeah, I didn't get a sugar lump, unfortunately, but I got my.
Give out sweeties. By the way, thank you to the person who sent cakes into the office for Easter. It was lovely. Robert, thank you so much for giving up your time. Again, I know you've got 4 o'clock.
Thanks.
James, hopefully we'll see you soon. We'll get some dates off you. We're going to continue these Thursday things. Good luck with the vaccinations. I'm sure you'll do well. I wouldn't like to think how many times you've stuck a needle into a patient. Think about that.
Yeah,
because you're pretty ancient.
Hopefully get the right part, yeah.
I'll give you a clue. Get them to take down their top, right? So everybody, thank you for joining us.
Last time I did that, I got arrested, but never mind.
Thank you for joining us, everybody. And we will be back next week. We've got Palak Trivedi, Dr. Trivedi, who James mentioned earlier. Robert, try and enjoy some of your time off. And we'll speak to you all soon. Thanks, everybody.
All right, take care all. Thanks, James.
Thanks.